Alright guys, for treating the iliolumbar ligament, what I want you to do is I want you to get your patient seated in front of you on a stool or a chair. If you're going to be having them on a chair, make sure that the back side of the chair is off to the side so that you have full access to their lower back. What you're going to be wanting to do is find the PSISs and find the iliac crest and locate in around the area where you think their L5 transverse process is. Now there's going to be a lot of tissue back here. We've got skin, superficial fascial tissue, we've got the multifidus, there are the erector spinae muscle groups, the multifidus, we've got the QLs. And depending on the size of the person, their musculoskeletal developedness, if it's a child, if it's an elderly patient, if it's someone that is sitting a little, they're a little larger, or if they're an athlete, if they have a protective mechanism that's happening in through the lumbar spine because of injury or perceived injury or threat or danger to these tissues, sometimes it's really hard to locate where the transverse process of L5 is. So it's best if you can find the posterior superior iliac spines, run your fingers up to the top of the iliac crest and just find sort of the sacral sulcus. There should be a little bit of a divot or a dip in through here where you can find the approximate area where the transverse process for L5 is. Now we have to remember our forced coupling mechanisms for the L5. So in a neutral position, when our patient side bends to the right, this vertebrae should actually rotate to the opposite side, so we should rotate left. When this patient side bends to the left, it should also rotate to the right. So that's the rotational coupling mechanism of that lumbar spine. When the patient forward flexes in a neutral position, the transverse processes should actually climb up and they should climb down nice and evenly. Now, nobody ever is symmetrical. Nobody ever has normal bilateral symmetrical engagement, neuromuscular engagement of the lumbar spine. But when you've got someone who is complaining of discomfort and pain and a decreased quality of life, we want to try and improve that symmetrical bilateral neurological engagement as best we can. So what I want you to do is to get your patient, after you've found the transverse process of L5 on each side, I want you to get them to bend forwards, and you're going to see if this transverse process, if it climbs up nice and evenly, or if it side flexes to one side or the other. We're really good, the research has shown that manual therapists, we're really good at finding the hyperstability area. We're finding the point where it's really, really locked down or protected. So what I want you to do is look to see if it's a little bit side flexed when they go into a forward flexion, and then I want you to get them to side bend one way and side bend the other to see if you can figure out where that rotational force coupling dysfunction is. So again, when they side bend to the right, you should lose your thumb. It should create a nice sulcus in through this area. The tissues should relax a little bit so you can actually palpate deeper into that transverse process. When they side bend to the left, again, it should rotate to the right, to the opposite direction. And if you can figure out from them bending forwards that if it's side flex to the left and then also it's not rotating to the left, you can tell what kind of dysfunction it is. It's a side bend left dysfunction with a rotation left dysfunction. So the goal in that instance would be to try and create some distance or some space or decrease some neurological engagement in through this left L5 transverse process and iliolumbar ligament in order to have that ligamentomuscular reflex engage so that we can get a decreased neuromuscular engagement and protective mechanisms of the tissues in through this area. So again, find the PSIS, find the iliac crest, find the transverse processes of L5, have your patient bend forwards to look for the side flexion force coupling dysfunction, have them side bend right and left to look for the opposite direction rotational force coupling dysfunction, and this is where we will start our treatment with our patient. So let's go to that video. Okay guys, in this video we're going to be instructing you on how to work with the iliolumbar ligament. The iliolumbar ligament, according to the research, has been shown to be one of the main stabilizers or main influencers in creating pelvic stability for the SI joints. And there's been some research that's actually shown that in cadaveric studies, when they've severed the iliolumbar ligament, that you actually get an increase in range of motion and an increase in instability through the SI joints. There's also been some research that shows that when there's a laxity to the iliolumbar ligament, that patients typically complain of a sense of hypermobility through the pelvis and predominantly to the sacroiliac joints. Also, when they've gone through and had some type of therapy, prolotherapy, PRP, where there is an injectable therapy that causes a tightening of the tissues, the patients tend to feel like there's more pelvic stability through the SI joints. So what we're going to do is work with the iliolumbar ligament. The research also shows that we are great at finding the part of the motion of the segment that has the most amount of stability. So what we do when we're looking at iliolumbar ligament, we're going to assess where we find a lack of mobility, and then we're going to treat that. Now, we're quite aware that there is a lot of anatomy between the skin and where that iliolumbar ligament is. It's a good, inch and a half of tissue. So really, this isn't a direct technique because we can't directly palpate that iliolumbar ligament. But what we can do is we can influence it with movement of the patient and position of our thumb over top of that L5 transverse process. There is a research paper that was put out by Miguel et al. That stated that there is a skin fascia frictionless interface, which showed that when they, basically the research showed that you can't hook underneath the transverse process of a specific vertebrae and force a specific direction to that vertebrae. It can't happen. It doesn't exist. The research has shown that that's true. So you have to change your narrative of how you describe what is happening where you're treating your patient. Now, with that skin fascia frictionless interface, they did state that the only way that you could really make contact and influence a joint is either perpendicular to the structure, or if you are going to be able to lever it. So with this technique, what we're going to do is we're going to aim to be very perpendicular to that transverse process of the L5, and then we're going to use her body mechanics in order to influence that iliolumbar ligament. But if we want to engage the multifidus, the erector spinae, the lats, the soft tissues of the body, well, then we can use a little bit of a hook underneath in order to influence those tissues. So that's what we're going to be doing with this technique. So first off, what I want you to do is I want you to get crouched down behind your patient. Your patient is seated here, and I want you to find the iliac crests, find the PSISs, the posterior superior iliac spines. There should be a little bit of a divot that you can fit your thumbs into, and this is where that L5 transverse process and the iliolumbar ligament should be. Remember that the iliolumbar ligament only comes from L5. There was a lot of myth and trend that thought that it came from L4 also, but there's been a ton of research that's shown that predominantly it is L5 and it runs over to the iliac crest, and it also interdigitates with the interosseous sacroiliac ligamentous tissues of the SI joint. So find iliac crest, find PSIS, come up into that sacral sulcus where the little divot is. We're going to have our thumbs exactly at the same level. And what we're going to get Annabelle to do is just slowly bend forwards. Keep going, keep going, keep going. And right about there, as you can see, there's been a change. So there's a little bit of more stability here. It looks like there's a little bit more movement on this left side. And what we want to do is we want to sort of engage this tissue to become and get treated in order to end up so that they both move evenly together and come back up. Typically in practice, what I'll find is that patients will either complain of pain on the side that has the movement, or they have pain on the side that has the lack of movement. Now, I never tout myself as a therapist that treats pain. I tend to try and treat function more than pain, because pain is just a huge multi-dimensional event and thing that we need to look at a whole variety of influencing factors there. But if I can create some balance and some stability, and I can create sort of a change, my input as a manual therapist can make a change to the neurophysiological function of her nervous system, well then maybe we can change whatever side that she's complaining of discomfort on. Maybe we can change those messages from being a danger and a threat message to being more of a biomechanical, kinesthetic, proprioceptive message is what we're trying to attain. If I get a change in pain, then fantastic, it's a great treatment. But I'm predominantly looking for a change in function of this L5 area. Now, with L5, we know that when the patient is in neutral, that when she goes to side bend to the right, this L5 should rotate left and I should lose my thumb. And when she side bends left, then it should rotate to the right and come back up. So we know how to elicit a rotational functional pattern of this L5. We know how to elicit a side flexion pattern to this vertebrae also. So what we need to do is decide and assess what the function is of this vertebrae right now. So we've already had her slowly bend forwards. So as you can see, there's a side flexion to the left, or sorry, to the right that's happening, and come back up. And when she side bends right, there's not a lot of rotation to the left that's occurring. And let's go side bend. And there's actually not a lot happening to the right also. So that might seem to me that is just her normal rotational pattern for that vertebrae. It seems pretty balanced, but it doesn't seem to be as much as what I've seen in the past. So what I'd like to do is get a little bit more functionality happening in this L5 on the right-hand side. So what I'm going to do is lock my thumbs into that sacral sulcus where that L5 iliolumbar ligament is. I'm going to get her to slowly bend forwards and go there, stay there. I'm going to take my other thumb and lock it in place. Now remember, the skin fascia frictionless interface says that I can only influence a joint perpendicular to it. So I'm loading just straight posterior to anterior. Now if I really want to influence that iliolumbar ligament and open up this facet joint, then I'm going to get her to slowly side bend to the left. So left, I can just start to feel it there. And also thorax, rotate to the left too. So rotate left. There we go, right there, perfect. So as soon as she does that, when she's in a forward position, then the vertebrae starts to work a little bit differently. Whereas when she's in a neutral position and she side bends left, the vertebrae rotates right. When she's in a forward position, when she side bends left, the vertebrae also side bends left and rotates to the same side. So now we're really influencing this iliolumbar ligament to open up this facet joint. We're loading it from a posterior to an anterior direction. If I want to engage the soft tissue, then I will hook and engage the soft tissue. But I know from the research that if I predominantly want to influence just the iliolumbar ligament, then it's just a posterior to anterior 90-degree technique. So we hold this technique until we feel a softening occur in through the tissue. We're getting a neurophysiological change that's occurring. Let's have you bend forwards a little bit more. There, good. Little side bend left. There we go. And then let's have you slowly come back up nice and straight. I'm going to give a little bit of resistance. Good. And let's reassess. So again, iliac crest, sacral sulcus, find that position. Let's have you slowly bend forwards. And as she bends forwards, now this vertebrae and the soft tissue come up nice and balanced. So there's that, and come back up. Now, if she had a rotational dysfunction where it rotated one side more than the other, then what we could do is a couple of things. We would locate the iliolumbar ligament again with both thumbs. And what I'm going to get her to do is just to side bend to the right, because I want to influence that vertebrae to the left. And I'm going to get her to extend back towards me, so that slackens. It's sort of like a positional release technique. And then you can load again from a posterior to anterior to influence that vertebrae to rotate to the left. We'll hold this and wait for a softening to occur. There we go. And then slowly back up, nice and straight. And then we'll reassess. So let's have her side bend right. There we go. Oh, nice. And then side bend left. Okay, so now there's not as much side bend happening on the left. And back to normal.
That's where I actually get most tenderness.
This is where you get the most tenderness?
Yeah, when people work there, that's really tender.
Okay, so it gets a little bit hypersensitized. How's it feeling right now?
Oh, good.
Okay. Let's have you slowly bend forward. We'll just reassess this and back up. Okay, so that is how I assess with ligamentous articular strain technique, how I assess for a side flexion dysfunction and a rotational dysfunction for this L5 S1 area and where the iliolumbar ligament is. This is also how to influence the iliolumbar ligament with a posterior to anterior direction based on the research from that skin fascia frictionless interface report, and also to work with the soft tissue by creating just a little bit of a hook underneath the tissue. We've got some nice movement happening with the L5, and we've got some change that's happening to the iliolumbar ligament. So that concludes this technique for this patient.